And I will introduce myself as we go, because I have a slide where I can show you exactly what that is. So how many of you know that we have 5 pandemics going? Now, so we do have 5 pandemics going, and I would tell you why we have those 5 pandemics going. The title of this is Effects of Environmental Toxins on the Growing Estrogen, Obesity, Allergy, Immune Complex, Anxiety, Depression, and Virus, Bacteria, and Candida Pandemics. So those are the 5 pandemics that we have. That's why I have a title, Quad Pandemics and the Fifth Estate. The fifth estate is the bacteria, virus, Candida pandemic. I have 4 books that I wrote. The latest one is called The Layman's Guide to Integrative Immunity. So integrative immunity is actually my brand. I coined that term, integrative immunity. Some people talk about integrative immunology, but I came with this term, integrative immunity, in 2014 or so. As we go, again, you would understand why. But I came from the Ivory Coast. I don't know how many of you know the Ivory Coast. And if you don't know and you love chocolate, think about the Ivory Coast, because they're the #1 producer of cocoa to make chocolate in the whole world. So many people don't know the Ivory Coast, which is French speaking, but they know Ghana. So it's next door to Ghana. And I came here in 1980. So I've been in the United States for 42 years or so. And I came for graduate school. I came to study economics. So I did my PhD in economics. And after that, I taught economics for about 7 years before I went to medical school. When I was teaching economics, I was taking classes one by one and stuff, because I always wanted to be a medical doctor. But in Côte d'Ivoire, the Ivory Coast, where we had the French system, in junior high school already, they direct you into one field. And I was good for economics and social sciences. So I never had a chance to do anything with the basic sciences or anything like that. But when I came to the US, I found out I could still do medicine. So while I was teaching, I was taking classes to go to medical school. Eventually, I went to the Medical College of Ohio, where I did my training. And after that, I did my internal medicine residency at Ohio State. After the internal medicine residency, I did a fellowship at GlaxoSmithKline to combine my economics and medicine. Now, my goal of going to medical school had always been to practice medicine, not only to do research. So luckily, I got a fellowship at Johns Hopkins where I did my allergy and immunology training. Now, because I had the teaching background, after I finished that training, I said, well, maybe I should go to a university setting and teach. So I got a position at the University of Texas Health Sciences Center in Tyler, Texas, and as an associate professor of medicine. So while I was teaching, one day, my colleague, who is a pediatric allergist, said, hey, Benoit, we have a meeting in Dallas and one of us has to go. It's not going to be me, you go. I said, who cares? I'm going to go there for 5 days, enjoy myself, and that will be it. So I went to the meeting, and it's a group of family physicians and ENT physicians who get together through what they call the Pan American Allergy Society, and they learn how to do skin testing, and they introduce allergy in their practices. As you understand, I have a fellowship, 2 years fellowship training in allergy and immunology. So that part did not interest me much. But what I learned from that group is that there was someone, Dr. Stephen Hotsey, who did a presentation on hormones and how the hormones affect this, hormone causes this, hormone. I said, whoa, Why didn't I learn this in medical school? Why didn't I learn this in residency? And why now? And plus, this group that learned allergy in 5 days, maybe I should go and learn hormones and try to know more about it. So I went and bought literally all the books on hormones in the market and tried to read them. The more I read, I found out, wow, the hormones actually play a major role in allergy as well. How? Because I found out women in the mid-30s, they did not have allergy before, but in the mid-30s, all of a sudden, some of these women are having allergies that they cannot explain. They have food allergies, food sensitivities, they have asthma, they have all of these things that are showing up. And when I traced it to the hormones. So that led me to write the first book called The Allergy Detective, Allergic Rhinitis Treatment Secrets Your Doctor May Not Tell You. Because I found out about that secret. Because most of the time when these women show up, we didn't know what to do with them. We did skin testing on them, it's negative. So the pathway through which they have the allergies is not through the usual IgE-mediated pathway. So then after that, I start questioning myself, what about obesity? Could this obesity be due to hormonal imbalance? And found out, yes, obesity definitely is due to hormonal imbalance, and the hormonal imbalance is due to environmental toxin affecting the hormones, and that is leading to obesity. So I came up with the Hormone Imbalance Syndrome, America's Silent Plague, the second book. Now, as I was going, I was thinking of how can I create my own little niche where I can combine the endocrine system and the immune system, because I found out that the endocrine system and the immune system are the two systems that drive majority of the chronic diseases. And that's what led me to the term integrative immunity. So when I created this book, or when I wrote this book, I thought I was going to write a professional guide, because I had the layman's guide. I want to write the professional practitioner's guide. But when I looked at it, it was going to be over 1,000 pages. So I decided I was going to turn that into a training program. And that's what I have done. So currently I do have a mentorship program that I'm helping healthcare practitioners use my protocols to get results. And currently our group, definitely we're getting good results with what we're doing. Now, if you have questions, please stop me and then we can go from there. This is going to be jumpy, it looks like. All right, so integrative immunity in the fifth estate. This is basically the outline. We're going to talk about backstory, the making of the medical detective. I told you a little bit about that. Understanding the government covert interventions, the government intervention timeline, the USGS, United States Geological Survey, pesticide maps. We'll talk about the obesity maps. We'll talk about the CDC fourth report. We'll talk about many of the chemicals, organochlorine, organophosphates, and other stuff. We'll talk about the second estate, which is the estrogen pandemic. How many of you know that we have an estrogen pandemic going? Most of us know, but we never really pay attention, but we do have an estrogen pandemic driving many of the problems that we see around. Mechanism of action of the estrogens and other chemicals in the CDC fourth report. The third estate is the allergy immune complex, or what we call autoimmune pandemic. The fourth estate is going to be the anxiety depression pandemic, and then the fifth estate will be the virus, bacteria, everything that we all focus now these days. The objectives, I'm not going to go in detail, but when we finish, especially if you do see the recording, you will know all these things that we're trying to connect. So our goal as healthcare practitioners, the old goal was to maintain chronic diseases with medications and also to prevent them by doing vaccinations. However, all of you who are in integrative medicine now, you know that our goal has shifted and we're trying to eliminate as much as possible the chronic diseases and also prevent new ones from forming. So to prevent and eliminate the diseases, though, we need to have a disease model. So how many of you have a disease model? When I graduated or when I finished my trainings, actually, I did not have a plan when I was going to practice medicine. I just went and jumped in like everybody else tried to practice medicine. I had no model, I had nothing until I started thinking about it. And then I came up with a model that works better for the patient care. So when we have providers and we have patients, there should be a happy medium. So providers' welfare and patients' welfare. Most of the time when we don't master what is going on, then we're not happy and the patients also are not happy. So we cannot get to this happy medium. What is a model? The model is a representation of a theory, and a theory is the explanation of the mechanism behind observed phenomena. So to create a model, we need to understand the states of health. How many states of health do you guys think we have? Usually, I say that we have 3 states of health. That's why when we see people say, hey, good morning, how are you doing today? When we ask them that question, we expect them to elicit something, to tell us something. But most of the time in America, when you say, good morning, how are you doing today? They say, I'm okay, I'm well. Even though they do have problems, nobody's going to tell you about the health problems, so we don't know. But otherwise, we expect people to say, I'm well today, I'm doing great, or I'm under the weather a little bit, maybe I got a cold, or maybe I have something chronic going with me. If you can help me out with it. So these are the 3 states that we have. When we have the 3 states, I came up with transition probabilities. I really think that many of us don't think of transition probabilities, meaning if a person is well last month or last year, if we meet them today, what would they be? Would they be still well? Or would they be transiently sick? Or would they have any diagnostic of, say, diabetes or blood pressure or other ominous things, cancer or something else? That could happen. But if they're transiently sick as well, they can be well, or they can remain in the state of transiently sick, or they can be worse. And if somebody is really bad, like they have diabetes and stuff, it's not a life sentence anymore. We all know that they can get well if we take care of them, or they can transition to a moderate kind of diabetes situation where their blood sugars will get better sometime and sometime will not, or they can remain in their old state. Now, based on this, we can calculate what we call transition probabilities, where we take each state and we divide by the stock from which they came from. So for instance, if we have the chronic disease people, we take them and we divide by the people who started here at year 1 or beginning of a year. That gives us the probability. And the determinants of that would be the endocrine system, or the interaction effect between the endocrine system and the immune system that I said explains about 95% of the chronic diseases. Patient-provider value ladder. So I don't think that I have seen anybody talking about the provider or patient value ladder. So this would be my own doing, something that I created. I call it value ladder because if we think that health is our best value, our wealth, we put that on the vertical axis and health and price on the horizontal axis. If people are chronically sick, well, we're maintaining them, we're giving them a lot of medication to keep them here at the bottom of the ladder. Or they will have less wealth because they have less value. Our goal as integrative medicine practitioners or functional medicine practitioners these days is to move individuals who are in this at the bottom to being well all the time. So if we can move them from here to here, then they achieve more wealth and more health. But that will command a little bit of price, right? Because if we're going to move them from here to here, they're going to make efforts on their own. They have to eat better. They have to do all of those other things that would ask them to do. but they will need to pay a little more. For instance, if I come to the functional medicine person, they're not going to pay the same as if they were paying through their insurance. They will have to pay a little more, but they will get more for the value. So if we want to give them value, we have to move them on the ladder to the top of the ladder, from the bottom to the top. Now, there are major things that prevents us from being at the top of the ladder. I think we have a practice environmental mismatch. Most of the time, when we see the patients, there are some environmental factors affecting them, but we don't take that into account. So because of the mismatch, we cannot answer their question. We cannot help them. So the patients are not happy and the practitioners are not happy. Do you guys know the #1 complaint of patients? #1 complaint of patient is that doctor never explained to me my problem. They never taught me anything about my problem. So I want to know what is wrong with me, but my doctor really did not explain my problem for me. So they have a graphometer, and the graphometer, the #1 thing is a clear explanation of problem. Then you have all these other things like test results that are not communicated in time, billing, dispute. Reason is if people are not happy, they don't understand, then if you billing them, they're not going to be happy about that either. So they're going to do disputes and stuff like that. Sometimes when the patients come and people don't understand vitamins and other stuff, all of a sudden they say, well, you know, why do you go to these doctors who are giving you all these vitamins and supplements and all of this? So they don't want to really understand it. So the patient don't like that. So the doctors who belittle the other doctors, they don't want it. So if you do that, the patients tend to think you are arrogant and you have a bad bedside manner. So they're going to give you bad reviews. And you know, these reviews these days will go into how much patient you get later on. So these are some of the things that the patients are saying. So are we prepared to address these common 21st century patient complaints, which is the #1 complaint, or do we feel burnout? Well, most of the time, if we don't know what to say and stuff like that, and the patient comes, we have no answers for them, then we feel burned out, we feel overwhelmed, etc. Like this lady, this man, they're all tired. So I said that integrated immunity is probably the solution to some of these questions or these problems that we're having. If we train well and we understand what is happening, then we can help our patients. Now, the integrative immunity process, I call it PCR. We pre-qualify the patients, we connect with them, we do a review of system and physical exam, then we educate them and we make recommendations. How many of you can do a review of system in 5 minutes? So a lot of times we all do this, but we don't really learn to do a review of system in 5 minutes. So if you guys know, you want to know that, I can help you do that. And every time I teach, I do some of these review of system really in 5 minutes, then people can learn how to do it. So integrated immunity model. And what is integrated immunity? I told you it's how the endocrine system and the immune system work together to cause probably 95% of the chronic diseases. So the interaction effect is what we're looking for. So these two systems have increased malfunctions, and the malfunction is causing the effect, the detrimental effect, which is the disease that we see around. So environmental effects on the endocrine system and the immune system, what is the evidence? If I'm thinking that the environment is causing problems, so is there any evidence at all? Well, let's talk about the backstory. What is the backstory of all of that? So early 1980s, the CDC all of a sudden discovered that some states are gaining weight abnormally. So they proceeded to investigate. So in 1984, they created what we call the Behavioral Risk Factor Surveillance Survey. They passed a survey around, people filled them out. 1985, that created the first obesity map. And obesity was only in 8 states. It was Georgia, South Carolina, Kentucky, West Virginia, Ohio, Indiana, Wisconsin, and North Dakota. And guess what? The rate was only 10 to 14%. So back then, we were screaming and kicking and saying, oh, we got obesity. But now, the rate has reached more than 40% in some states. So not only obesity has taken over the whole North America, Canada, US, Mexico, the whole world has become obese in 40 years. So by the World Health Organization, it comes by 2025, couple of years from now, we do nothing, there will be 2.7 billion people overweight worldwide. So it's a pandemic. The problem is if you ask the CDC or World Health Organization why we gaining the weight, they think it's a calorie in, calorie out problem. We eat too much, we're not exercising, and that's why we gaining the weight. It doesn't add up. Because if it were true, the whole United States would be uniformly obese. But it's not. How many of you know that obesity is actually concentrated in the middle of America, from the upper Midwest all the way to the Mississippi and Bayman states? And every single year, Mississippi is the driver. It starts in Mississippi, Alabama, Louisiana, Kentucky, West Virginia, and then it goes upward like a tree every single year. So I'm going to show you some of those things, and then we can move forward. So who am I? I talked to you a little bit about that. I talked to you, these are the seminal states, the state that had the obesity to begin with. Like I said, the CDC map, the first map in 1985, this is what we had. Now, 5 years later, look what has happened. The blue, for 10 to 14% has taken over the whole US almost. So is the government doing anything to help with this stuff? Well, the government is doing something. They're trying to figure it out. And at the same time, so the CDC is doing the maps, but at the same time, the USGS is also publishing pesticide maps. So my thinking is, the reason the obesity starts in Mississippi is because, do you guys know where the Mississippi River starts from? I suppose so. It starts from Minnesota, and it traverses the whole United States and goes to Mississippi. But the big rivers such as Ohio River, the Missouri River, they all dump into the Mississippi, and they carry with them whatever would do upland. So my thinking was maybe the pesticide that we spray in the farmlands are killing us all, and they're causing this obesity pandemic that we see around. So that was what I thought. I didn't have any evidence whatsoever, but I wanted to prove that. So I looked everywhere. I called the whole United States to find the pesticide maps, and finally somebody in Washington, D.C. said, yeah, we got pesticide maps. I took the pesticide maps and I matched them year by year, and they matched perfectly well with the obesity maps. Now, when I did that, the USGS actually invited me in 2011 to do a presentation in Denver for them. And when I showed them the maps, they were blown out. So, whoa, so you mean that the maps that we're creating can actually help you solve some medical problems? I said, of course, you guys do it, but we're not connecting with the CDC to try to come up with solutions to problems that we're having. Anyway, these are some of the pesticide maps. We have 2,4-D, which is the herbicide. We have glyphosate, of course, so all of you have heard about that. Look how sparse it was. It wasn't that dense like it is now. And then atrazine. How many of you know of atrazine and what it does? Of course, with the work of Professor Tyrone Hayes out of Berkeley, we know that atrazine in water converts the male frogs to lay eggs. So the male frogs can lay eggs. That means this chemical is really bad. It's an aromatase booster. It converts testosterone to estrogens. So that's why amphibians are laying eggs. The male ones are laying eggs. So atrazine is not really good for us. Alachlor affects the nose, so we can have nasal cavernous enlargement, as well as we can have thyroid problems. Metolachlor does the same thing. And as you can see, the Corn Belt has a lot more of it. And Metolachlor S, that I don't put the name here, but it's Metolachlor S also does the same thing. Now, the government is passing laws. So we have laws against pollution. Well, from 1947 until now, so many laws. But who is actually watching out for the laws to be obeyed? The farmers do what they want, and we're not finding any solution to our problems. So we know we have pollution, and the pollution is causing problems, but yet we're not really doing a whole lot to try to find out what to do with those laws. In 1990, for instance, do you guys know that we passed an Organic Food Production Act? But since then, how much organic food are we producing? Not much at all. So those continue. Now, I asked what causes disease in the 21st century. I think that is extrinsic factors such as pollution, microbial accidents, and intrinsic factors such as genetic and malformation. Even the genetics and malformation may be due to the pollution, because currently we talk about epigenetics, which means how the endocrine system, pollution is actually affecting our genes and causing more malformations and all these birth defects that we see around. What are today's major health problems? We have the growing estrogen pandemic, the growing obesity pandemic, the growing allergy pandemic, the growing anxiety, depression pandemic, and growing virus, bacteria, Candida pandemic. How many of you know that there's one Candida that is actually contagious? At least we have found one Candida that is contagious. It is called Candida auris, A-U-R-I-S. And the CDC is actually worried about that Candida. So if you go to their website, you will see that Candida is not so benign. And we're seeing that in people's mouths and stuff. We don't really make much of it, but it is becoming really bad. So what are the root causes of these problems? Well, I think, can we use multi-specialty approach to answer these questions? I don't think so. I really think we should use integrative immunity approach to solve these problems. Now, more problems: environmental allergies, food allergies, chronic sinusitis, chronic candidiasis, chronic recurrent viruses. As we go, have more atopic dermatitis, migraine, headaches, hair loss. When you see people in clinic, they come up with all these problems: abdominal problems, bloating, cramping, constipation, diarrhea, IBS, IBD problems, Candida overgrowth problems. So the Mayo Clinic actually came up with 10 major conditions that we see in clinic overall. And many of them, the skin disorders, osteoarthritis, of course, as you know, those are related to obesity, back problems, cholesterol problems, upper respiratory conditions, anxiety, depression, bipolar disorder, chronic neurological disorders, high blood pressure, headaches and migraine headaches, and diabetes. Those are what the Mayo came up with, but I have more to it than that. So you can see the rest here: hives, urticaria. Now, for instance, we have so many women after COVID who have hives. We wonder why so many women have hives. What is going on? Why the women? Why not the men? Some men too, but not much, but it's a lot of women having hives when they get COVID or they get the COVID vaccination. Angioedema, hypoglycemic episodes, we have decreased libido, and brain fog. These two go together all the time. So my joke is 10 years from now, there will be no offices and there will be no babies. So the species is going extinct because everybody got brain fog and decreased libido. Sleep disturbances, eating disorders, abnormal weight gains, morbid obesity, hypothyroidism, Graves' disease, all of these things, and then et cetera, et cetera. You can see so many conditions that we're seeing now in clinics and nutrition. So I said, how do we maximize health and outcomes? To do that, we have to know the body, we have to know our environment, and we have to know the foods and beverages. So to know the body, that's what I said, we need to do a questionnaire. So when the patient comes, we give them a 27 pages questionnaire. They fill it out. It gives us a lot of information about them. And then from there, we can answer some of the questions. Now, we need to have evidence-based, and the evidence-based, I always go to the government because I really don't want to put out things that I cannot substantiate. So I use the HCAP database, and the HCAP database allows me to make these statistics. For instance, if I take migraine headaches, who has more? I know that it's a lot of women who have migraine headaches. About 83% of all the discharges in 2012, 904,000 discharges from the emergency room, women, 83%. What part of the country, what regions have more? We found that it's the Midwest and the South. And I did control for population, because you will tell me, well, the Midwest and the South have more population than the rest of the country, so it's evident. That's not true. Even if you did state by state, you will see that still it's the same thing, that the Midwest and the South states do have more than everybody else. And if we take IBS, irritable bowel syndrome, the same thing, when we see that women have more, 75.68%, and then still Midwest and the South. And it's concentrated in the prime age females. If we look at other things such as myalgias, fibromyalgia, the aches and pains, the same thing. And it's a lot of women, about 65%. But this time it's about Northeast and the South that have more. So know the environment. How many of you are familiar with the CDC fourth report? Now, when I do presentation for A4M or other organizations, people don't know the CDC fourth report. The CDC, since 2001, has been measuring chemicals in our blood and urine. And every single person that tested has chemicals in them. As a matter of fact, the children are born with more than 280 chemicals in their cord blood. So it is not surprising that we have so many babies who have brain tumors and all of that. If you go to St. Jude website, we see all these babies 3 months old, they have brain tumor, wonder why. Well, that's because they're contaminated from utero, and that's what is happening. But unfortunately, the CDC finding the chemicals in you and I, since 2001, the conclusion has been, don't worry, don't panic yet, we don't know what is going on, maybe, and they keep on drawing the same conclusion. But I'm thinking that these chemicals are not bystanders. I think they're causing problems for us, and that's why we have so many of the chronic diseases. So the CDC fourth report would allow us to draw the conclusion that we have an estrogen pandemic going. I don't want to click on those that these are clickable, because if I click on it, it will lead us to the CDC fourth report and we can see it. But I put them here. For instance, if you hear, but tell us not to drink out of plastic bottles, not to heat plastic, not to do that. Why? Because of BPA, right? But why did they come up with that anyway? Well, I found out that young girls, some of them are getting their period by age 7. So we have precocious puberty that is going on. And they say, well, this is due to estrogen. So what is estrogen? They say, oh, it's BPA. So everybody is down to BPA, but the big chemicals that are actually causing the estrogen problem, nobody's talking about those chemicals. So if you look at the CDC fourth report, we see that many of the chemicals actually kill the thyroid. For instance, your PFAS and perfluorocarbons, they're all thyroid disruptors. Now, do you guys know who coined the term endocrine disruptors? Anybody? Or it was Theo Colborn, and Theo Colborn and her colleagues, Dr. Myers and others, they published a book called Our Stolen Future. And Theo, I think 1991 or so, they had a meeting in Wisconsin, and she came up with this term endocrine disruptor. So now everybody uses it, but most of the time we don't know even the source of it. I had the chance of speaking to her when she was in Colorado before she died in 2014. But she has a lot of information on YouTube videos, TED Talks and stuff like that. So Theo Colborn, she's a big person in terms of endocrine disruption. We have thyroid disruptors. We do have estrogens like bisphenol A or bisphenol F. We do have more estrogen here in terms of old things that we have banned that are still persistent in the environment, like Ordran, DDT. DDT was abolished in 1972. And I think all of you probably know who was the person who actually went and publicized that DDT is bad for us, that we should not have it in our environments and all of that. Rachel Carson, our Silent Spring, she came up with all this information, and then people went along and they abolished it. But DDT, even though it's abolished, is still persistent in our environment. So it's one of the dirty dozen chemicals. And so these ones here, many of them are the dirty dozen chemicals. They're all estrogenic. They make your estrogen go up. Now, many more here, the parabens, all the deodorants and the perfumes, they all have parabens. If you look in the back of these, they all have estrogen in them. Metals, mercury, cadmium, lead, but all estrogenic. And then if you look at many of the other chemicals, they make your acetylcholine go up. So a lot of times people don't realize it. We have all the organophosphates and carbamates that are acetylcholine esterase inhibitors. So they make acetylcholine available in our blood so we can have acetylcholinemia. And the acetylcholine, as you will learn soon, is not a bystander either, because we see so many people with anxiety, depression. We have the kids with ADHD. All of those people probably due to the acetylcholine excess. Many of the chemicals make the insulin go up. So it's not surprising we have many people with diabetes and all of that. More estrogen. So if you look at this whole CDC4 report chemicals, majority of them make the estrogen go up. The PCBs and all of them, they're all estrogen compounds. This big group is estrogenic, so I can just skip. So my conclusion by looking at the CDC4 report is that we have an estrogen pandemic, but we're not really paying attention to those estrogen pandemics because we're not quite clear about it. But it's becoming more and more clear that estrogen is a big problem. So my conclusion here is that we do have estrogens, not only the chemicals, but also some of the food that we eat, like the wheat, the barley, the rye, the spelt, the kamut, the millet. Those are phytoestrogens. So if you have too much estrogen, even if you did phytoestrogens, they're not going to help you any. That's why we have so many women who have gluten sensitivity. They eat gluten, they get bloated, they get crampy, they get diarrhea, they get headaches, they get mood swings. Oh, I have gluten sensitivity. But when did this gluten sensitivity come in? Well, it turns out the farmers actually in the Midwest, they're very ingenious. Somebody found out that before harvesting the wheat, they can spray Roundup on it. In the mid-1990s, they started doing this practice, and all of a sudden, we cannot tolerate the wheat anymore. We eat the wheat and we're sick. But 1,000 years, people ate bread, they had no problem. Now we eat the bread, we cannot do well. So all of you probably are familiar with Dr. Davis' book, Wheat Belly. He talks about other conditions like genetic modifications and all the things that have contributed to the wheat being bad. But I think the phytoestrogen component is not negligible. Estrogen pandemic, so what? Well, turns out these estrogen, when they're high, they cause a bunch of problems, allergy problems, as I will show you soon. They cause accelerated aging, they cause adrenal exhaustion, they cause cold hand, cold feet, all kinds of stuff, decreased sex drive, depression with anxiety. Now we have tons of people with depression, anxiety, dry eyes. I mean, it goes on and on and on. A lot of symptoms that are related to estrogen overload. PCOS, for instance, young girls now, 13-year-old, they have PCOS. You wonder why so many young girls, they're having PCOS, polycystic ovaries. Why? That's because of the estrogen, the plethora of estrogen in our environment, driving all of these conditions. Obesity driving many of that too. And then you can see all of these things are due to estrogen. So the estrogens are not benign. They're causing a lot of problems. They're causing a lot of condition symptoms that the patient present with that we're not identifying them as such. So mechanism of action of estrogens and other chemicals in the CDC4 report. So I put the golden links. I start with environmental chemical poisoning through knowledge from the CDC4 report that cause negative externalities such as cancers and all of that, that they make your estrogen go up. The estrogen lead to obesity, and I can show you how that works. And then the estrogen and obesity can lead to immune deficiencies or immune defects. And then that we have bacteria, viruses that are going to proliferate. We have allergies also that come in, and then we're trying to fight them. And then we have anxiety, depression, and that leads to broken relationships. And I can show you the maps, and you will see that there is some connection between anxiety, depression, and broken relationship, but that comes from all the way up here till we get to that. So if we have organochlorines such as DDT, or we have the organophosphates, let's start with the organophosphates in our foods. If you eat non-organic foods, those foods are contaminated with these chemicals, and those chemicals lead to acetylcholine production. Too much acetylcholine, those have receptors on your mast cells and basophils. So when they're attached to the receptor, they cause histamine and leukotriene release. So all of a sudden, we're having more and more allergies around. Not only that, the acetylcholine also has receptor on the islet cells, the pancreatic islet cell. So through the muscarinic receptor 3, that goes through a cascade, and the end product is insulin. So if we eat food that are contaminated with organophosphate and carbamates, we're going to produce more insulin. So it's no surprise that we have so many diabetics. Now, the insulin causes obesity. Of course, we know that we get insulin resistance, and the obesity leads to leptin resistance. And I will show you how that works. And the leptin resistance leads to diabetes, and leptin resistance and insulin resistance leads to diabetes and all of that, but unopposed acetylcholine. So when we have leptin resistance, the acetylcholine is unopposed, and then we have more of the acetylcholine causing problems. So this cycle right here, and it never ends. Now, when we have too much insulin and we have obesity, also we produce more estrogen. Why? Because obese people, they produce aromatase, and that aromatase from the fat cells leads to conversion of the testosterone to estrogen. So when we have too much estrogen around, these estrogens have receptors on your mast cells and basophils. It's called estrogen receptor alpha. So when they attach to the receptor, they cause histamine and leukotriene release. So all of a sudden, we're having so many people with allergic reactions. Not only that, when we have too much insulin, it causes a proliferation of the mast cells and the basophils. So not only do we having more numbers of these mast cells and basophils, but then they're being degranulated. That leads to a lot of allergic reaction. That's why we're seeing so many people now with allergies going on. When I lecture, usually I ask people any questions about it, because I know it's like I'm putting the fire hose in your face, giving you all this information in a very short period of time, but it's a lot of information. Anyway, organochlorines do the same thing like the DDT and others. When they're in our food or in our environment and we get exposed to it, they go through the sodium channels on the pancreatic islet cell, and then they drive calcium into the cell, and eventually we end up with insulin. Again, the same scenario, we're going to have more cycling with obesity, leptin resistance, unopposed acetylcholine, more insulin, and then etc. So effects of chloroacetamide, these are newer pesticides that came in, such as the alloxychloroquine. I told you a little bit about that. Those cause nasal-turbinate enlargements, and they cause thyroid disease. So now, all of a sudden, we're having so many women who have Hashimoto's, they have Graves' disease. We don't know what to go with that. Well, certainly that is because of the chemical that we have in our environment. So to talk about thyroid, I think many of you know how the thyroid works. Now, phenylalanine is the beginning material to make the thyroid. The phenylalanine goes to tyrosine, and the tyrosine goes to dopamine, and the dopamine goes to norepinephrine and epinephrine. Now, the catalyst to go from phenylalanine to tyrosine is iron. That's why it's always important when you're testing for the thyroid to also test ferritin, which is your iron stores. Because if you don't know what the iron is doing, you may not know exactly how the thyroid is working. But many people don't test for the iron. They just test the TSH, and that's it. Well, 4 molecules of iodine get attached to the tyrosine, and that becomes T4. The T4, the tyrosine, the 4 for the 4 molecules of iodine. Now, that is the beginning. This beginning thyroid hormone is not quite active yet. To be active, one of the iodine gets chopped off by the deiodinase, the enzyme, and then that becomes T3, and the T3 is the active thyroid. Now, while it's going to the T3, that T4 also goes to reverse T3. The reverse T3 is a competitor of the T3. So if we have a cell with receptors for the T3 and the reverse T3, and we have plenty of reverse T3, then to the body, it feels like we have low thyroid. It's not going to work. So that is one of the major issues. The other thing that happens is that when we have SSRIs or we have all these chemicals that I'm showing you, well, these chemicals, many of them that are perfluorocarbons and stuff, they have fluoride in them. And that fluoride substitute iodine on the thyroid, on the tyrosine. So now we cannot make T4. And if we can't, then the thyroid is not going to work. That's why we have so many people with low thyroid, the thyroid is not working. Now, the conversion of the T4 to T3 requires some vitamins. It requires some supplements. So all your B vitamins, all your minerals will be good to help convert more of your T4 to the T3. But what makes the T4 go to reverse T3? Low progesterone, too much estrogen overload, low selenium, low zinc, low potassium, low vitamin D, low iodine, low all of that, and too much cortisol. Turns out this is what is happening to a bunch of people. So then many people are converting the T4 to the reverse T3. But if we find that somebody has low thyroid, guess what we give them? All of a sudden, we give them Synthroid or levothyroxine or even Tyrosine, which is better than the other two. And yet, they're not converting that to the active form. They're going to reverse T3 because they have all these conditions existing. We also see the coexistence of anxiety and depression with low thyroid. So many women who have low thyroid or have Hashimoto's or stuff, they also have anxiety, depression. Why? Because it's the same pathway. The tyrosine goes to make dopamine and all of that. So if this is not good, then they're not going to make all these neurotransmitters. And if they don't, then they're going to have mood disorders. Now, glyphosate, which is Roundup, actually tends to reduce the production of phenylalanine, tyrosine, and tryptophan. Those aromatic amino acids, when they're reduced, then we're not getting enough of these things. Our neurotransmitters are not going to work. Our thyroid is not going to work. So we're going to have problems. Now, the shikimate pathway from the bacteria, the gut bacteria that produce some of this for us, that shikimate pathway is disrupted when we do have the glyphosate around. And that's why many people, again, may have depression, anxiety. Not only the glyphosate is estrogenic by itself because they grew that with breast cells and they grew like wildfire. So it's no surprise why since the mid-1990s, we have so many women with breast cancers and all these female cancers. That's because of too much glyphosate around. The anxiety depression pandemic. So if we're talking about symptoms of high acetylcholine, if you look at it, it mimics the symptoms of high estrogens. They exactly look alike. So too much acetylcholine can appear like we have depression, anxiety, we have all these things that are happening to us. Again, if you look at this, you can go and check this reference that I put in here, and it will give you more information about this. Depression, anxiety, how do we test it in 5 minutes when people come? We talk about their sleep, their interest, if their interest has changed pleasure-wise, are they feeling guilty, doubt, self-doubt about certain things, energy levels, concentration levels, appetite, psychomotor activity. Like this, we observe if they have psychomotor agitation or retardation, and then suicidal ideation. If we ask them those questions very quickly doing the CG caps, that allows us to determine whether they have depression or anxiety. Again, looking at some statistics, we can see that for recurrent depression, psychosis, etc., severe females, 60% Midwest South have more. When we look at more, you can see the diagrams, how things have changed. One of the things that you may want to pay attention to is the years in which things changed. It looks like since 1997, 1998, things have changed a lot, very drastically for all these conditions. And the number one reason is we introduced glyphosate in our food chain on a larger scale in 1994. That's when the GMOs came in. So all of a sudden, since 1997, so there is a lag effect of probably a couple of years, 3 years, but all of a sudden things have gone down here since we introduced that. Anxiety states have changed. The same thing, Midwest and South have more of that. Women have more all the time. Catecholamine markers, we can go through that, but I just want to skip it and you can do stuff. So a lot of time, one of the, what I would say about this slide is that when we give nutritional supplements to people, we have to be careful. Why? Because if we give tryptophan-based supplements, they're going to urinate, and that is inflammatory. So people can have inflammation, they can convert that to urinate, and that can cause insomnia. So the patient will come and say, so I'm irritable, I cannot sleep well. We say, well, we don't know, maybe you need to take melatonin, all of that, but maybe it's the supplement that we're giving them. So we have to be careful when we give supplements to people. When we do the catecholamine testing, if they have low norepinephrine, low dopamine, low serotonin, we have to suspect acetylcholinemia, because when we have too much acetylcholine, actually causes these neurotransmitters to go down. Too much estrogen, we get anxiety, depression too. Why? Because the estrogen, they have the same receptors on our cells as the dopamine, the epinephrine, norepinephrine. So when we have too much estrogen, they bind all these receptors, and all of a sudden, we're not getting our good neurotransmitters in the cells, so we end up having more anxiety and depression. Now, these papers show you that. So what is common among pesticide overload, obesity, anxiety, depression, divorce? So this is my rendition of it. We know that we have pesticide overload that leads to more obesity. And if you look at the regions where we have more, this leads to anxiety, depression, the same region, and that leads to more divorce in the same region. People say, well, correlation is not causation. Certainly, but there's this is not the first time somebody is using maps to show things. The father of using maps, or what we call medical geography, is John Snow. And I will show you a little bit of that. So obesity pandemic, I told you already a little bit about that, the CDC and the World Health Organization ideas about obesity. Obesity trends, as you can see, it was slow right here, 1997, 98, boom, extra astronomical increase. It dips it down a little bit and then goes up continuously. It's not going down at all. It continues to increase. And we're not tackling the right reason we're having the obesity, so we cannot get results. If we all know that it's due to the pesticides and then think through it, then perhaps we can get a better answer to it. The Seminole state that had it, and if you keep an eye on it, you will see what I was talking about, that Mississippi is the driver, and you can see that Mississippi, Louisiana start that, and then it goes and goes upward like a tree. And it's keep on going. So looking at the obesity maps, and then Mississippi starts again, and you can see that it's going and taking over, and then the whole place is obese. Mississippi starts all the time. So when you pay attention carefully to the maps, you can see that Mississippi is the driver. And that's what I explained to you, that the river may be contributing to it. And more and more and more. And then 2011, we did changes. So you can see how things change. The map is changing and it goes up all the time. 2011, they changed the scale, but it's still the same thing. They changed the colors, but still the same thing. You can see that the orange one is 30 to 35%. The yellow one is 25 to 30%, and then so and more. When we look at by decade, you can see how things have evolved. They go tons of obesity maps. And then also morbidity and mortality. So the areas with the heaviest obesity, no surprise, also carry the highest mortality. Obesity types, we have the people with the ventral obesity, you have Australia, you have all of that. Those people, they have insulin problem, they have estrogen problem, because look at the guy, he has gynecomastia. I'm really so surprised these days I see so many men with gynecomastia. That's because we have too much estrogen in our environment driving that. This hip type definitely is estrogen, too much estrogen. This one is estrogen and the cortisol, and all of those guys who have the ventral obesity, they have too much cortisol going. This one I call it obesity à deux. So people who are even not related, who live in the same family like husband and wife, but tend to have the same obesity pattern. I call it obesity à deux. The two boys, they have obesity, same thing. They're eating the same food, they're drinking the same water, but end up having the same obesity. So why should we care? Well, we know that obesity is the mother of all the diseases. So if we pay attention and solve this obesity problem, then there will be no more of these conditions. So are there any relationship between agrochemicals and obesity? Well, that's what we're going to see. So I talk about a little bit about Theo Corbon. I talk about people who talked about this thing, Rachel Carson. I did discuss that very briefly. The 1990s, though, I personally started my own little movement talking about the pesticides and obesity and how all these things are connected. Talk about John Snow, the father of medical geography, because a lot of times people say, well, what are you doing? Causation, correlation doesn't mean causation. So John Snow is the first one who talked about that, and I follow his lead to show that, yes, definitely if we have obesity and we have pesticides, if we look at the regions where we have more obesity, we can see that that region corresponds exactly to the place where we have more pesticides. For instance, if you see the streak going down here, that is going through the Mississippi River. You can even see the pesticide driving through. I didn't make this map, by the way, it's the USGS who created it. Now, the same thing. This is one pesticide. If we take another pesticide, the same region that has more obesity has more pesticide that it goes through the Mississippi River. Again, you look at this one, same thing. It goes through the Mississippi River. So it's no surprise why Mississippi starts with obesity than anybody else. And the same maps, I mean, I show several of them just to make the point. Questions about any of those things? All right. Now, allergy and autoimmune diseases, immune complex diseases, biology pandemic. All of you know the environmental working group that came up with the Dirty Dozen foods. I really don't think that we have Dirty Dozen. I think we have Dirty Thousand. All the foods are dirty. Peanut did not make the list, and peanut is dirtier, by the way. And I have done more studies showing that because of the pesticide that we use in cotton, and we rotate the cotton with the peanut, definitely the peanut is more contaminated. That's why we have so many kids with peanut allergies. So the contamination in our peanut makes the European Union and Israel our best allies not to want to buy our peanut anymore. So they buy the peanut from Argentina. We're trying to do the best to to bring them back, but they still buy the peanut from Argentina because ours is contaminated. Food allergy trends, if you look since the mid-1990s, 1996, 97, we have a change. Peanut anaphylactic reaction, for instance, was going down. 1997 started going up. If we look at angioedema, it was going up flat, and then 1997 is gone up. If we look at peanut allergy, it was right here, 1997 started going up a lot. If we look at celiac disease, it was down, 1996, 97 started going up. If we look at some paper, Nancy Swenson and others, they did a correlation study that showed that if you look at the yellow one, that's celiac incidence, and then the black line is glyphosate, the advent of Roundup. You can see that since Roundup came in our food chain, we have more people sensitive to gluten and celiac disease. Now, if we take things like fish allergy that does not use pesticides, well, we don't have such a trend. If we take other things that don't, anemia, for instance, iron deficiency anemia, it was flat right here in 1997, astronomical increase. So it's important then when we see patients to check the iron, because many of them have mineral deficiency, magnesium, zinc, iron, and we're not giving them all these minerals, then they're going to complain of aches and pains and tiredness and all of these other things that they will complain about. But simple iron or simple magnesium therapy can control many things, including even blood pressure. Allergic urticaria, you can see definitely we do have a lot of women who have it, and in the South and the West. Idiopathic urticaria, same thing, we have more women who have it, and then so it's all these three, Northeast, Northwest, and South. And then glyphosate induces cancer, so the papers that have been written, you can actually look at those papers and you can see those references. Chemicals in food production in the United States, for instance, if we take wheat, you can see all these chemicals that goes into our wheat. And it's not benign. Many of them, I mean, they really cause bad stuff. So that's why we cannot tolerate the wheat anymore. So whether it's a spring wheat or a winter wheat, they all use the same chemicals. So here I give you a table where I looked at the effect of these chemicals on allergies and aromatase and everything else. And it looks like they're all really bad for us. The virus, bacteria, candida pandemic that I told you about, you can see that the areas where we have more obesity, more everything, definitely will have more antibiotic-resistant bacteria that are growing. And it makes sense because the bacteria, what do they use to proliferate? They use sugar. So if you have plenty of glucose around, they're going to proliferate. Same for viruses. If we have too much sugar around, they're going to proliferate. Same for candida. If we have sugar around, they're going to proliferate. But who has more glucose? The people with obesity have more glucose. So in essence, we're fostering these bacteria, viruses, and candida from our state of obesity. So all these things show that, and I want to put it together for you, how all of these things come together. This is the house. It took me a long time to build that house. So I don't expect you to be able to build it in 1 second, but I'm going to just summarize it for you. So I give you the foundation here. I'll start with estrogen. I told you that we have estrogen pandemic. Those estrogens, when they go up, they make your insulin go up. When the insulin goes up, your blood glucose goes up. And the insulin is the #1 fat maker. So what it does, it takes the excess sugar and puts it into fat cells. Simple mechanism. So since we have this plethora of estrogens, all of a sudden we're having so many people with obesity. Now, when the fasters are filled up, they're not happy. They send a messenger called leptin to the brain to complain. When the hypothalamus gets the leptin, says, okay, guys, I will help you. Send a message down, decompress, leave me alone. But nobody loses the weight overnight. So they don't see the result. They send more leptin, more leptin. Now we get what we call leptin resistance, because we have plenty of leptin, but the brain is not perceiving that anymore. When we have leptin resistance, serotonin production goes down because there's an inverse relationship between leptin and serotonin. So all of a sudden we have anxiety, depression, panic attack that set in. Now to treat the anxiety, depression, and stuff, what do we give them? We're going to give them antidepressant, the SSRIs and stuff. And what did I tell you? Those things contain fluoride or stuff like that as binder. And that fluoride actually goes to inhibit your thyroid. So that's why many times when we put people on these antidepressants, all of a sudden they gain weight. And we don't know why they're gaining the weight. That's because the antidepressants are suppressing the thyroid function. So when we have leptin resistance, that leads to insulin resistance, simply meaning the insulin now being plenty has no capacity of pushing the lower fasters around to get the sugar in them. The sugar spins the blood, and high levels is what we call diabetes. I also showed you that when we have too much acetylcholine, that can lead to insulin resistance. So we do have in our environment a lot of chemicals that make acetylcholine available. So then all of a sudden we're having more insulin resistance, diabetes, and everything else. Now, when we have too much or too many of the fat cells, they cause inflammation. They produce TNF-alpha and IL-6. So all of a sudden, people are having aches and pains, joint pain, muscle pain, back pain. They're having allergies. Women, they're having asthma that they didn't have before because the fat cells are producing those cytokines for them. Now, we learned from COVID that the people who die more of it are people who are obese. Why? Because they get cytokine storm. The cytokine storm comes from the fact that people who are obese already have an underlying inflammation. They have TNF-alpha, IL-6, and many other inflammatory markers. And so now that we get COVID, the B cells and the macrophage and all of the other cells, they're producing all these cytokines as well. So the body becomes overwhelmed, and then the people don't make it. So that's what is happening. Now, when we have fat cells around, they actually help your skin cells and adrenal glands to produce even more estrogen for you. So when I see people with obesity, I don't even think twice. I say, well, you got estrogen problems. Why? Because as I said, people are producing aromatase. The fat cells are producing the aromatase, and the aromatase convert the testosterone to be estrogen. As the testosterone is going to be estrogen, all of a sudden people are getting brain fog. Because remember, the testosterone is this thing that says, yeah, let's go climb trees, let's be creative, let's do that. But if we don't have it, so okay, go away. I don't want to do anything. You cannot think straight. People names don't come so easily anymore. And so we're losing it. When we have too much estrogen, they cause benign tumors in women. They cause fibroid tumors, fibrocystic breast disease, ovarian cysts, endometriosis, cervical dysplasias, abnormal pap smears. But those are the benign ones. We get also candida proliferation. Why? Because having insulin around, making too much glucose, the candida loves it, so the candida is going to proliferate. That's why so many people have candida overgrowth. But that's not the worst of it, because the estrogen that causes cancer in women, that cause 7 cancers: breast, uterine, ovarian, vaginal, cervical, colon cancer, and for men that cause prostate cancer and colon cancer, and lung cancer for men who never smoke. Women also lung cancer for women who never smoked. Now, when we have too much estrogen, the thyroid doesn't work, because too much estrogen, the protein that carries the thyroid hormone around, known as the thyroid binding globulin, gets bigger. So the more we have of that, the less the thyroid would work. So to the body, it feels like we have low thyroid. Now, I told you about many women now, they're having Hashimoto's. those Hashimoto thyroiditis or those thyroiditis, whether it's Graves' disease or Hashimoto, they're all related to too much estrogen. That's why women have more of that than men. When we have too much estrogen, they also cause coagulation factors. So a lot of people, for instance, there are some women who go on birth control pills that all of a sudden their coagulation factors are not working, so they get blood clots and they get blood clots in their lungs and all of these other stuff. So they're all related. The other thing that I can say is that when we have problems with, we have stress in our lives, the stress leads us to produce more cortisol from our beginning hormone, which is pregnenolone. So if we're making more cortisol, then we're not going to make our longevity hormone called DHEA. If we're not making DHEA, well, the testosterone is going to go down because we have low progesterone, low DHEA. That the top line, they feed into the testosterone, but the testosterone is going to estrogen. So if the uplines are low, then we're going to have low testosterone, and the low one is going to estrogen. That's why we have this low T phenomenon. So many people, they have low testosterone around, and men are going to get all kinds of testosterone supplementation and everything else that goes on. Too low testosterone, that leads to too much insulin, and then the insulin causes this problem. We cannot burn fat, so we get flabby, we get all these abdominal problems that goes on, abdominal growth, girths that is going on. So all the men having big abdomen because they're having low T. I'm just feeling some of these things just in terms of time. So when we have low DHEA and the insulin goes up, we retain salt in our kidney tubules and the blood pressure follows. So all of a sudden we have high blood pressure. So we have too much glucose, we get diabetes, we get blood pressure problems. And these are the things that we treat in clinics, but understanding this diagram is not one thing that many people do. And eventually, when all our hormones are off, then the body is smart. So the body is going to increase the LDL cholesterol, which is the starting material to make the hormones. So as our LDL is going up, people think, oh boy, we're going to die of a heart attack. So they start giving us statin drugs and all of that. Now, of course, there was a JAMA article that showed that if we give women statin drugs, they get more diabetes. Why? Because, of course, we make cholesterol from glucose, glycolysis, and we make from the beta oxidation of the fatty acids. Those two lead us to acetyl-CoA. The acetyl-CoA is the one that leads to cholesterol, and the rate-limiting enzyme is the HMG-CoA reductase. So if we block this HMG-CoA reductase with a statin drugs, then where does the glucose go? Well, it spills in the blood. So then we get more diabetes. And that's a very clear understanding of that. Now, does cholesterol really cause heart attack? Well, it turns out these days papers have been written that the triglycerides are actually worse. And it's true. Turns out that when people thought that cholesterol, and Keys and others thought that cholesterol is bad for you, fat is bad for you, we weed out the fat, we weed out the cholesterol, people died of heart attack anyway. Then we look at the Africans, they're eating all this saturated fat, then they're not getting heart attack. Why not? Turns out when you eat saturated fats like coconut oil and avocados and all of these other stuff, what they do, they tend to make your large particle LDL larger and your small dense particle is not growing. The small dense particle is the bad one. So now we have the lipoprotein fractionation test that can allow us to measure the small dense particle LDL. But how many of us do it? A lot of time people, we still do the old cholesterol test and we say, oh, this is enough. And then we start giving people statin drugs when actually maybe what is big is the large particle LDL. We don't have to give them that. In order for the small particle LDL to cause problem, we have to have homocysteine around. Now, homocysteine is the byproduct of metabolism. It's an amino acid, circulates in the blood and poke holes in the arteries. So as it's doing that, the small dense particle LDL lodge in the holes and form inflammation. Now, macrophage monocytes, they hate inflammation. When they see that, they come around to clean it up. They eat so much of the cholesterol remnants, they become obese, and we call them foam cells, right? Those foam cells, they wallow there and die. More of them coming to clean up. They die and they're forming the cemetery of white blood cell called plaque. If the plaque is big enough, it obstructs the vessel lumen and the heart muscles are not fed, part of it dies, we call it heart attack. If the brain is not fed, part of it dies, we call it stroke. So the name of the game is called oxidation of the LDL. So why don't we prevent it by doing some antioxidants? That's why personally, when I see patients in clinic, I give them a lot of antioxidants because I don't know who has what. Now we know there's a group of people in the population who cannot absorb their B vitamins. Why? Because they have the MTHFR mutation, and they have the mutation that cannot absorb their B vitamins or their folic acid. So now we have to methylate the B vitamins or the folic acid for them to absorb. And so many vitamin supplement companies are methylating their B vitamins and their folic acid for absorption. And that's why this came in. As I said, the estrogen, they have receptors on your mast cells and basophils. So when they attach to the receptor, they cause histamine and leukotriene release. In this diagram, I show you also, in the interest of time, I'm just going to fill it out, but I show you all the supplements that you give to your patient, where they intervene, where they come in. And you can use this diagram definitely to help the patient by looking at what supplements and stuff you can give them. The blue ones are all the supplements that we give to people. So the connection between that diagram and the next one is through here, estrogens. Estrogen receptors, we have leukotriene, histamine release, we get an allergic reaction, we get hives, we get all of those things that come in, etc. And then food allergies, same thing, we get all of that. I don't want to go into the details. Now we're having even worse conditions called the mast cell activation syndrome. What is activating the mast cells? So all these patients will show up with all these symptoms. But what is activating the mast cells are the estrogens, the acetylcholine, the insulin causing them to proliferate. So all of these things are affecting the mast cells, causing them to pour out their granules. That leads to all these things that we see around. So when we talk about mast cell activation syndrome, we never talked about the chemicals that are driving it. We don't talk about the hormones that are driving it. And here, I try to show you a little bit how all these things are connected. When people get COVID, they get more hives. Why? Because when we get COVID, we make antibodies. We make IgG, and that IgG, IgM, the IgG especially has receptors on your mast cells. So when it attaches to the receptor, it causes them to degranulate as well. And then complement is activated, it causes degranulation. So that is leading to all the hives that we see when people get the COVID or they get the COVID vaccination. Again, I show you the receptors on your mast cells and how all these things can cause the mast cell to degranulate. Basophils are exactly the same thing. I don't know why people talk about mast cell activation and they don't talk about basophil activation. They should. That the reason histamine is so bad, histamine affects everything. So when the histamine is released, it will cause problem with the central nervous system, cardiovascular system. They get tachycardia, hypotension, they get all kinds of things with them. They get flushing, they get hives. Well, these patients who are having histamine problem, that's why people talk about histamine-free diet. But when we talk about histamine, low histamine diet, what we don't tell you is that those low histamine diet are also estrogenic. So maybe estrogen-free lifestyle is a better way to go. And I'm not going to go deeper, but I think that's where I stop. Questions?
Very good lecture. You missed my lecture last week, but it kind of follows a lot what you were saying. I gave a lecture last week on the ancestral diet. So what I tell my patients is, if you cannot buy organic glyphosate-free foods, just focus mostly on beef, because cow has 4 compartments of the stomach, and it can potentially filter out a lot of these pesticides a little bit better. So that's what I recommend to my patients mostly, is following more ancestrally appropriate foods.
Right. So now with the beef, one of the major problem is if you talk to the people in the Midwest, all of a sudden you will find out that the way they feed the beef cattle, they give them hay, they give them grass in the beginning, and then 3 months before they butcher them, they give them corn. But the corn they're feeding them is GMO corn, so it's contaminated, and it goes to the beef and it's contaminated. And so we eat that, we get sick on it. So I think that's one of the major reasons we have this beef not working. And that's why grass-fed organic beef is so expensive, because they don't want to put all these things in.
Exactly.
Questions?
Anybody else have any other questions, comments?
How do you detox your patients with glyphosate poisoning?
So Dr. Isaac Elias, actually through his website, he does have a compound called Glypho Detox. So he's giving the patient Glypho, a detox product to clean out the glyphosate.
Oh, interesting.
So there's a Glypho Detox that you can have out there and clean the glyphosate with. I give that to the patient all the time. They like it.
Look this up.
Other questions?
The cruciferous vegetables here are usually things we discourage the patients with thyroid disease from eating, or at least staying away from raw ones. So how do you balance that?
Yeah, I personally don't believe that. I really don't think that the cruciferous vegetables cause much trouble for the thyroid at all. I don't agree with that. And so I know what is causing the problem with the thyroid is the estrogens. So for that reason, I really tend to take out the gluten, the dairy, the soy, so all the estrogen-free diet that I give to people, that's for that reason. Then they can eat the cruciferous vegetables that actually are going to help them, so then they can make more of the good estrogen.
Do you find trying to lower the antibodies in the thyroid patients is useful at all, or no?
Oh, absolutely. Actually, I have so many patients who had antibodies in the thousands. When I put them on the estrogen-free lifestyle, they all do very well. The antibodies all of a sudden start coming down. Also, when I detoxify them, the antibodies start coming down. So you can see the results.
Question in the chat is, we order Aricept to increase acetylcholine in the brain of patients with this dementia. How does that fit in with your theory of high acetylcholine?
Well, so that is one thing that I don't necessarily agree with. For instance, we know that dementia or Alzheimer's is due to what I call turbine. So it's a toxic overload, hormonal imbalance, infections, and nutrient deficiencies. So when you clear all of these things for the patient, you detoxify them, you correct their hormonal imbalance, low testosterone, and all of these other things. If they have infections, you take care of it, you give them all the nutrients they need. All of a sudden, the patient wake up. They do much better compared to if you did not do those things. So I think the approach should be a little different than just giving them something that is going to cause more problems down the road.
Okay, great. Anybody else have any questions?
Yes, I have a question. How do you determine which detoxicants you use? I mean, how are you specific in the way you detoxify patients?
Yeah, so you have the phase 1, phase 2 detox. Now, but a lot of times, many of the companies that give you the phase 1, phase 2 all combined. So for instance, Core Restore by Orthomolecular helps you detoxify the liver so the liver can detoxify the body. So that's what
Okay.
most of them are doing.
Okay, thank you.
Sure.
What do you do about the high cortisol in the women and men?
So the high cortisol, actually, I give them a cortisol calm, something, Pure Encapsulation has a product called cortisol calm. So I give them that, and it does work very well. But fortunately, all the companies, the good companies that make nutritional supplements, that tend to give you also those things. They give you their version of cortisol calm.
Lost the. Try it now, Dr. Benoit.
Yeah.
Okay, we lose the sound there for a minute.
Oh, okay. Yeah, I'm on.
I think we're okay now.
Yeah. I think people are putting things in the chat. I don't know.
Okay. What is your opinion of low-dose naltrexone in Hashimoto's?
So that is one thing that I never used, because all the other protocols that I'm using are working so well. I never really use low-dose naltrexone.
Okay.
For me, doing things naturally as much as possible has worked out very well. So in my protocols, for anything, for Hashimoto's, for any of the things that I do work, so then I don't really see the need of using the low-dose naltrexone.
Okay.
Do you have a standard estrogen-free diet you use?
Yeah, I do have estrogen-free lifestyle, I call it. And
Okay.
I have it of even, I have a place on my website where people can send their patients. So if some of you are interested and you want to send your patients to our website so then they can learn more about this and help them with the estrogen-free lifestyle, I would like to discuss with you and see how we can do that.
Okay, thank you.
Can you
Sure.
put in the chat your website there, Dr. Benoit?
Okay. So the site is called, but I have to walk people through it. It's called TireProNetwork.com. So with TireProNetwork.com, our network, so when you go there, you sign up. I think Dr. Clearfield signed up on it. So if you sign up, then you have access to a bunch of stuff, but just look at health, look at nutrition, look at all of that, and it allows you to glean through things that have videos, that have a lot of information there for many people to learn, even take courses if they want to. Oh, by the way, I put Dr. Clearfield, I put this forum on our network as well. So
That was unsolicited, by the way. So.
Right, it was unsolicited. Actually, I decided to put it on because it's so good. Because all these lectures that people have been doing has to be in one place. So I put it on our TirePro network. So people who are interested, they can probably have access to it and they can watch it there.
Oh,
Do you like doing iodine and selenium in those with the hyperthyroidism?
Yeah, so if they have a hyper or hypo.
You do both. Good.
Right. Yeah, because I mean, Dr. Bernstein and all these other people, they tend to think that iodine deficiency is the big problem that we have. But I think it's a conundrum of a lot of stuff. The toxic overload, the hormone imbalance, and infections and nutrient deficiencies. So we have to fix all of them together rather than just focus on a few things.
What's the optimal reference range for T3 for you?
With T3 for me, it has to be 3.5 or higher. So free T3 should be 3.5 or higher on a scale up to 4.2, right? So we should get at least 3.5. Now, by the way, do you guys know that low free T3 carries more cardiac risk.
Hmm.
A lot of people don't know that. So if you have a patient who consistently has low free T3, you have to be careful because they can have a cardiac event. That is a signal. So you have to make sure that they're getting enough thyroid.
Jeez, I don't think I have anyone with a 3.5 T3. Maybe
It's
one.
always so lower.
Yeah, everyone has low.
Okay,
T3.
well, so that means you have to really look at the whole thing. I always do free T4, free T3, reverse T3, and TSH.
Always. Natural sources of iodine. Do you like Celtic sea salt, kelp, things like that?
Yeah, sea salt, kelp, and all of those will be great.
And selenium, what, sardines and Brazil nuts?
Selenium, sardine, Brazil nut, also methionine and stuff like that, that the supplement companies put out, like pure encapsulations.
Yeah.
Anybody else have any other questions? So every once in a while, I'll come across someone who'll have a TSH of like 4.8, 5.0, and then a free T3 of about 3.86 or 3.7. I've got about a half a dozen of those people. So what do you do with those?
Yeah, so sometimes the lab, so I have been battling with the labs. The labs make errors and it doesn't make any sense. If it doesn't make any sense, I send the test back to them and say, you know what you did, it doesn't make any sense. And by the way, I did do that with one company, and we went all the way to the Mayo Clinic because the Mayo Clinic had the same errors. So then they couldn't fix it. And they keep on giving me the wrong ranges and it doesn't make any sense. So you have to be really suspicious when things don't add up.
Okay, well, what about, again, I have a handful of patients where it's pretty consistent that those are the numbers that we get.
Yeah, it could be the lab. So I don't know which lab you're using, but make sure that the lab you're using is not making mistakes.
I've been recently learning about optimal temperature ranges to determine thyroid function. What do you think about
Yes,
that?
I agree with that. So the basal temperature actually tends to be a better gauge of low thyroid. So if they're always in the low 90s, 96, 97 all the time, that may indicate low thyroid.
I think we were taught 97.6, lower than that.
Right.
Right. So
That's cold.
okay. In fact, so my father was in a personal care home during COVID, and we had to go, every time I went to go visit him, they took my temperature, and it was consistently 97.2, 96.8, 97.2, and guess what? So,
Yeah.
Wait, what'd you do? You get on thyroid medicine or what?
I don't have thyroid, man. I use the pure encapsulation. I just use the supplements. That seems to hold.
Yeah, you can. Yeah, so pure encapsulation has something called thyroid support complex.
Yeah, that's the one I use.
And that has tyrosine and iodine and stuff. So if you do that, then it helps.
Mm-hmm.
Yeah.
Mm-hmm.
What about T4, T3 together?
The compounded T4, T3, occasionally people cannot do well on the natural desiccated pig thyroids. I actually do that, but I have been lucky. I use the NP thyroid. Now, the problem is those are not stable. Most of the time they're out of stock or something. And so then you use the compound on them, that's fine too.
So what about in the fillers and the coating and all? So Armour Thyroid, it's had an issue with that. And have you found?
I agree. Armour Thyroid actually contains gluten, by the way. So some patients gain weight on it. So for that reason, I personally don't do Armour Thyroid a lot. If the other ones like NP Thyroid, West Thyroid, and all of these others are available, I'd rather use those than use the Armour Thyroid.
Right. It's NP Thyroid's a lot less expensive also.
Right.
So, okay. So can you give us a brief summary?
So a brief summary is that we do have environmental toxins that are affecting. So my acronym is Tobin. When we see chronic diseases around, I think it's Mr. Tobin's fault. Mr. Tobin is the culprit. Toxic overload, hormone imbalance or biologics, I call it biologics, so hormone imbalance, infections, and nutrient deficiencies. If we can solve these problems, so we can look at these 4 major components, then we can solve majority of the chronic disease, including dementia, including Alzheimer's disease. But most of the time, we look at one thing and we look at this, we look at them in the silos. And if we do that, we're not going to get results. So what integrative immunity does is to use this whole picture of toxins affecting hormones, hormones affecting other hormones and causing more problem for everybody else. And then you have the immune system that comes in with all the antibodies to cause more problem for everybody else. So we need to understand that picture. And many times people don't, because they don't master the allergy and immunology portion, which I master. They don't master very well the hormone portion either. So then you are in between and it becomes very difficult. And environmental wise, I think in medical school, all of you would agree, we didn't learn nothing about the environment. And the 21st century is made of environmental toxins. And we're not really taking that into account. That means we're not going to be able to solve many of the problems that we have.
Mm-hmm. We have our Dr. Patel is on tonight, and she's one of our resident environmental specialists. You've been very quiet tonight, Dr. Patel. Are you there? So she's on. So anyway, anybody else have any comments or questions?
Yes. My question is, it was mentioned about cocoa coming from the Ivory Coast.
Correct.
And I have read lately, there have been a number of lawsuits saying that cocoa, especially cocoa powder, has lead and cadmium.
Yeah,
And
I really tell people don't eat chocolate. That's one of my things on my list. Even though I come from that country, I mean, I came here a long time ago, but I come from there, and the #1 producer of the cocoa, I tell people don't eat chocolate. The reason is it's estrogenic.
but it's delicious.
It is, but it can do harm.
Do you in? It's going to do
Yeah.
you in, Shell. So
And it has anandamide, which makes people happy. But yeah,
What about garlic? For instance, I tell people don't do garlic, and I get a flap for it. I had a patient who came, a nurse. She said, I said, don't eat garlic. She said, Dr. Tano, you crazy. What, you mean garlic? Come on. It's okay, sure. I'm just the messenger. I'm telling you, don't do it. She went home and she stayed away from the garlic. A month later, I get a call. Dr. Tano, you wouldn't believe it. I said, what? When you told me not to do it, I stopped eating garlic. And then I got into it. I thought I was going to die. I had so much abdominal problems with it. But children who have eczema, for instance, how many of you would think of testing garlic as one of their allergies? Many people don't. But if you do test children who have a bad eczema, you will find that majority of them have garlic allergy. They have an IgE-mediated garlic allergy, big time. So garlic is not really good. I don't tell people not to eat onion, they can, but garlic, I said, don't do it. Don't touch it with a 10-foot pole.
and we tell people to use garlic to lower their cholesterol, right?
Right. So garlic extract is another thing, because remember, they took the extract, the allicin or whatever it is in it, and they made the supplement with it. that would be okay. It's like a green tea, right? If you look at the whole green tea plant, it is estrogenic. But if you take a EGCG or you take L-theanine from the green tea, those are good portions that will help the patient, but not the whole plant. So is turmeric, by the way. Turmeric is estrogenic. So if you see a lot of patients who come, they say, well, you know, I have turmeric allergy. So what happened? Well, I ate turmeric and I got hives. I have all that. It's a lot of women. Well, why? That's because the turmeric is estrogenic. It's gas like soy. If they eat tons of turmeric and they have an estrogen overload to begin with, that is driving their hives, then they're going to get a breakout and they get more hives. I even have seen a man who had that. So he was eating cumin and all of that, or deciding he has all these allergic reactions he couldn't understand. And I said, take them out and then you will see what happens. And differently, he did much better with that.
Okay, great. Okay. Dr. Burgess, you have anything for us?
Yeah, I might as well ask because I was curious if do you treat, assist, or refer for thyroid cancer?
I refer for thyroid cancer because cancer treatment is not my specialty. And as you know, this country is very litigious. And because it's not my specialty and I don't know all the things that I need to do, certainly I can have a supportive role telling them not to do certain things or detoxify them and all of that. But I tend to say, okay, you better find someone who is smarter than I am.
Yes, thank you.
Sure.
I don't know. I don't know that we've come across anyone yet that's smarter than you. You think you've got it locked here.
Yeah.
Maybe Steve Hartman here, but that's about it. So, okay. Anybody else? Comments, questions? Thank you so much, Dr. Tano. And this was fabulous. And please don't be a stranger. Please come back. We have his website here, TAYA Pro Network.
Yeah, TAYA Pro
.com.
Network. Yep, .com. And if someone wants to get in touch with me, I can give you my number too. So let me just give people my number. So 953 or 952-737-8323. You get me directly and we can chat. Some people are interested in the course that I have. We can talk about that. I mean, I have the mentorship program. If anyone is interested in that, we can do that. I mean, people are getting really so much good value from it. I think it's amazing, especially people who do functional medicine. A lot of times you don't have the time to actually focus on it. You go to a weekend class, you come back, you forget it all. Here, what we do, we take you by the hand and step by step, we meet every Wednesday or every Tuesday, and then we'll go over cases after cases and try to hone it in. We add up the theory showing how all this is connected. And that definitely makes a big difference.
Okay, that's terrific. Okay, so we have that here, 952-737-8323. We have your email address. Like I said, don't be a stranger. It was a little difficult finding you. I always like to make sure, we're going to have folks on. So I know you said you were traveling, so.
Yeah, email address, diabtano@gmail. That's a simpler one.
Right. And so, John, we're getting together a pretty eclectic faculty here. If we decide we're going to do a live.
Yeah, the one other question I had is, are you going to be able to get Dr. Tano for our spring talk?
We're going to work on it.
I hope so, because this was a first-class lecture and you put everything together. Thank you.
Okay.
Sure, thank you.
We'll have to be nice to him from now on.
For sure.
It's so out of character for us. That's that's the problem. Okay.
Right.
Well, thank you all very much. And we got lots of great lectures. You know, thank you for being here. You know, we really appreciate it. And next week, you know, hide your children, hide your folks. We have Dr. Peter McCullough, you know, on. So please, you know, tell your friends, tell your enemies, tell, you know, whoever. You know, we try to get, you know, as we always do, try to get a nice crowd. And, you know, we've had him on before. We had him on last year. We had him at our conference last year. He's been a pretty good friend to us, for somebody who's so, you know, in such high demand and such a, you know, prominent figure. So, and he'll be here next Tuesday, same 8 o'clock Eastern, 5 o'clock Pacific. Dr. Tano, again, thank you so much. We'll put this on our website, and I'm going to talk to you about getting our AOSRD crop on your website too. Okay. We have more than 2 years worth of lectures.
Right.
They're all videoed. Most of them are. We have transcripts on also, and so I don't know who watches them. I don't get a count or anything, but there's lots of great lectures on there. So
Right.
So again, next week we have Dr. Peter McCullough. Michael Nelson will be the week after that. And like I said, I told you before, unfortunately my system went out and I lost my schedule. So we're still filling in a little bit. So anybody has anything who wants to present, please let me know. You know, we only bite on Thursdays. So this is, you know, a stress-free zone, especially if you're new at it, at presenting. This is a good way to get started. We're not CME credit, so you can talk about your programs, your anything you want. You can use brand names, and so we'll meet again next week. John, I'm glad you're feeling better.
Yeah.
It's good to see you. And Dr. Cruz, you know, keep an eye on him for us. And everybody else, have a great night. We'll see you again next week. This will be up on the website as soon as possible. Dr. Tano, I can't thank you enough. And you'll be hearing from us again. So one of the prices you pay for being competent.
Well, thank you for that. So definitely, I would like to be part of a group, and so we can make things better, further all the causes possible.
Okay. Do you get our emails for our things? Are you on our email list yet?
Yeah, that would be good.
Okay. Well, what should I use? This Gmail account?
Yeah, so drbtano@gmail. So I put it in the chat.
Okay, I'll do that. Okay, well, I'll make sure you get them. Okay.
All right.
Okay. Thank you, everybody. Good night.
Good
Have a
night.
great night, and we'll see you again next week.
Okay.